Okay, I think we'll go ahead and get started. Hi, everyone. I'm Allison Owenby. I'm from McGovern Medical School in Houston, and welcome to the Shine Academy Faculty Development Roundtable on unique approaches to interprofessional education. So today's session features three panelists that will share an interprofessional educational activity that they are involved with. And then we will move into breakout groups where participants can share with each other the IPE activities that are going on within their programs or IPE activities that they would like to implement. So first, a few nuts and bolts about the session. Each of the panelists will have 10 minutes to present their IPE activity. And then we will have about 10 minutes for large group Q&A. And then we'll move into breakout groups where we can share IPE activities that we're involved with. Please note the session is being recorded and will be posted to the Shine Academy website. And also, please mark your calendars for the next Faculty Development Roundtable on April 27th from 12 to 1. Don't worry, we'll send a save the date. Okay, so the panelists, let me introduce them. So they are as follows. First, we have Dr. Jacqueline Albin. She's an associate professor in combined Peds internal medicine at UT Southwestern. She is passionate about nutrition, lifestyle, and other environmental influences on health, and she teaches her patients and students to prioritize these areas. In 2017, Dr. Albin launched UT Southwestern's culinary medicine program in collaboration with dietitians and serves as a director, working to teach nutrition through hands-on cooking classes to medical students, residents, healthcare professionals, and the community. Dr. John Luke is an associate professor of pediatrics and the assistant dean for interprofessional integration at Dell Medical School. He led the creation and implementation of a 4-year longitudinal interprofessional integration curriculum for Dell Med students. In the 3rd year, Dell Med students embark on community service learning projects and interprofessional coalition building to address the health and wellness issues of the people in Austin, Travis County. Through this opportunity, they leverage their leadership skills and commitment to rethinking health to address health equity matters affecting our community. And Dr. Jennifer Swales, she's the general internist, residency program director, and co-director of interprofessional education at McGovern Medical School at UT Health in Houston. Her work focuses on promoting teamwork and diversity across the UME-GME spectrum to improve wellness and patient care. In 2021, her team received a grant from the Josiah Macy Jr. Foundation to launch a new initiative allowing interprofessional student teams to engage longitudinally with community members via telehealth to learn social determinants of health, systems thinking, and teamwork. All right, I'm really excited to have all three of those folks with us. And so without further ado, I'll turn it over to Dr. Albin. And please put questions in the chat and we will monitor that for the end. Okay, thanks.
All right, are we seeing slides successfully? Perfect. Okay, so I'm a sucker for a good pun. And so when I was making these slides, I thought, really, I see culinary medicine as an easy recipe for interprofessional education. And I'll tell you why. And it goes far beyond just thinking about physicians, APPs, and dietitians to many other areas as well. So just a bit of background, because since you're a captive audience, I have to talk briefly about my passion about why nutrition matters so much. We have very clear national and global data on this, and it's not well taught to health professional students. Maybe the dietitians are getting this, but the rest of us aren't. And so what we eat, and importantly here, what's missing from our diets, is our top risk factor for early death in the US and the top 3 for disability. Specifically, diet quality, there's data to show that this is driving nearly half of cardiometabolic deaths. So our top killer, one of the most expensive parts of our healthcare system, is reversible in many cases, and we really aren't utilizing nutrition as an intervention with the resources and support that we need to. And then if we look at the US's general health, and this does not even include children, which as a med peds physician, the rates in pediatrics are just alarming. But if we look at adults, 93% of us do not have optimal cardiometabolic health. So that means that many of us on this call would fit that pattern of not meeting optimal cardiometabolic health. And then when you add the layers of social and structural determinants, we have over 10% of US households now are food insecure. So access and then actually application of a nourishing diet is a problem. And yet we're not educating to set health professionals up for success. And so if we know that this is our top risk factor, and then we know after the pandemic that the people at the highest risk for complications from COVID-19 were people with metabolic health challenges and other risk factors that pre-existed, then we should have a lot of enthusiasm around how to reduce healthcare costs and improve the health of our communities by addressing it. And then equity, increasingly a mission for our institutions. Food security aligns very much with health, and we need to increasingly integrate that in the way that we're training our learners. And so I think health professional students are often the ones who are first exposed to a person's need around food and then aligning that with their health concerns. We're a great population to begin to draw the connections and get our patients set up with the resources they need. And so culinary medicine is one very rapidly growing movement that's only about 10 years old in terms of the current iteration of it, although there is literature dating back to the late 1800s in the British Medical Journal describing this as an educational approach. But current iteration of it is integrating culinary skills with traditional registered dietitian medical nutrition therapy and teaching learners how does this link into actual physiology of disease, human relationship to food socially and culturally. How do we teach them to critically assess the evidence, both nutrition science and also public health evidence? And then how do we take that to patient care settings for those of us that are seeing patients directly, that real life application? So I want to point out that this was a huge joy for us. This was the January issue of Today's Dietitian magazine. It was actually the cover story. And my dietitian partner and I were two of the individuals interviewed for it. And you look at the tagline here where she says, a collaboration, not a competition between physicians and dietitians. And unfortunately, many people have had mixed opinions about having more health professional engagement in nutrition and what you'll often hear as the food is medicine movement. And I see this as a huge opportunity to create a positive narrative around better collaboration, better team skills, and how we can use this huge problem that needs everyone at the table to solve as a model for better team-based care. So I've sort of just put 5 groups of people that initially come together as having a role here. So dietitians, I like to think of as the people who've always known this matters, and the rest of us just weren't listening. And how can culinary medicine and the food as medicine movement enhance the value of the work that they do by drawing attention to it, having better partnerships, elevating it within health systems? And then for physicians, I think that we're getting to a tipping point, and I'll say the ACGME is having a plenary on nutrition at their annual meeting in a few weeks, and then the AAMC and osteopathic body that's equivalent to AAMC, and then the ACGME are coming together in March for a nutrition and clinical practice summit. So there's going to be a national shift towards nutrition education being more relevant and hopefully something that we all take as a priority. But the first touch point for patients is often going to be a physician, and they're either going to say this matters or they're going to gloss over it. And so the first foundation of nutrition education for physicians is just understanding that it matters, even if they don't have all the answers, which is not what those of us who do this work propose that they should have. And then culinary professionals, think about the food service people that work in our hospitals. They're already part of our systems, and the culinary skills that they have in partnership with dietitian skills bring the full picture of what it means to make delicious food that's affordable and nourishing and efficient. And then nurses and other APPs, PAs, actually our PA students are one of the big groups that are involved in our culinary medicine program. And they often are the first face that a patient who's hospitalized is going to see, especially for nurses. And so including them in part of this gives everyone a stakehold in the importance of nutrition for health. And then I've increasingly had engagement from our physical therapists and other therapists because it's clear how they play a role. If you're Well, actually, as one of the physical therapists who made the case to me about why they should be included in our course, they said patients are learning how to move their bodies healthfully with us, and they're asking us questions about nutrition because they don't have anywhere else to ask. And so a lot of different therapists will be fielding these questions, and knowing how each person on the team plays a role is vital. And then all these other people are a big part of what we do. Social workers and counselors, behavioral health specialists that help people work through disordered eating patterns and the role that mental health plays in our food. And then community health workers have a huge role. And so I think we just increasingly can expand the table to say, how can the intersection of each expertise area advance something that really needs to have more attention in our health systems? So just to show you kind of like what this looks like in action, we actually have a clinical nutrition lab built circa 1975, and yet it still works. You can see that gorgeous flooring and blue countertops we have. And this is actually for our dietetics program. It's the clinical nutrition lab, but they graciously allow us to use this space to teach courses across medical, PA school. Our PT students, our registered dietetic students are included in the course as co-facilitators and peer mentors. So it gives them a role of leadership and peer development across professions. And then we combine, kind of as I alluded to before, we combine culinary skills, demonstrations, actual cooking class, and then integrate patient cases and application to real life with a lens towards learning the evidence and how to talk about it with our patients. So this is a couple years old now, but our first 64 students that went through the course, one of the outcome measures that we looked at on the survey was understanding the role of a dietitian in team-based care. And it's the bottom one I have here in the box. And it went from a baseline, of 37% of those students feeling confident to 93% at the end of the course. So significant increase in understanding team-based care around nutrition health. And we also found that there was significant adaptability when the pandemic hit. And fortunately, we are back in person in the kitchen, but we were able to apply similar concepts while students did this from their home kitchens, either alone or in groups. And we were still able to bring that collaboration together. And a few findings from that, which many of you've probably seen in your experiences, is that you can reach more students when you're able to pivot between virtual and in-person educational engagement. And it actually increases the opportunities for interprofessional collaboration when people have a lot of different schedules and they're in very different parts on campus. And then perhaps even better, it opens up cross-institutional collaboration opportunities. And then when we think about our learners' wellness, combating loneliness and then really creating relationships for small groups that might not have naturally formed is one of the benefits of having a virtual pivot option of this work. And then just sort of towards closing out my comments today, I want to point out that as educators, with the real estate challenges that we have in education, where we're always trying to cram in more to less space, you have to find the win-wins. And I really preach this as something that hits on wellness. And of course, it's about nutrition education. It's also about IPE. It's also about individualized education. And if we can frame the things that we do that are related to interprofessional education as having multiple benefits, we're more likely to get progress at our institutions in adopting them. And then lastly, this is what I mentioned earlier, that this is a national movement where we're getting more commitment from our governing bodies over education for medical students specifically, that this is our chance to elevate and bring in our health professional colleagues that add a lot to our education. And then you see down here, their last thing they say here, focus on interprofessional care and health equity. And then my last slide for you, just in case you don't know what food as medicine is or means, I think that we're moving across the country to recognizing how food security and malnourishment have to be addressed. that we have to normalize a nourishing diet for everyone. And then we need to be supporting both acute and chronic illness with food and in a prescriptive way. And then really thinking about how we support our patients that have unique and special needs. All of us recognize this takes a team. It's not any one person's role. And so I love how culinary medicine can be a bastion to innovative education and then also innovative patient care, which is what we're up to at UT Southwestern. And you can reach out if you want to learn more about that. So my dietitian, Millette, is a wonderful human. If folks want to know how to get more involved from a dietetic perspective, and then you can absolutely reach out to me as well. And I will stop there.
Thank you. Hey, Dr. Luke.
All right. Good afternoon, everybody. Greetings from Austin. John Luke with Dell Medical School. I'd like to share with you the third year of our interprofessional integration curriculum. And as I do, I want to recognize the contribution and leadership of Dr. Kelly Kovarik, my colleague in this course, and Stephanie Hinojosa Galvan, another team member who has been integral in lifting and moving this course forward. The interprofessional integration curriculum at Dell Medical School is really longitudinal and prepares our graduates for collaborative practice. So we're really focusing on opportunities to grow the identity, more importantly, the interprofessional identity of our learners, from socialization through integration of values for skill. And so I've highlighted the year in which I will focus my presentation today. Another way to look at this is thinking about Miller's pyramid, thinking about ways in which we can have our students demonstrate their work and show that they do this more than just show and know, and they can do so in ways that are much more meaningful. And so as I thought about this, I think about our role as physicians. And so for us at Dell Medical School, we're thinking about ways in which our learners as future physicians can begin to socialize and learn about, from, and with each other on the team, and moving into our year 2, which is our clinical year, learning about the patient, and finally into the community before thinking about oneself as a future physician on the team. So I'm focusing on the third year, which is really centered around interprofessional community service learning. And this course offers our students in core groups of 3 to 5 medical students an opportunity to look into our community, to build coalitions, to serve our community, to address health key themes and vision elements of our community health. We've been very fortunate in that our public health department put out a report around our community's health, in which it elaborates key themes and vision elements. And pegging the students' work in that report creates important relevance and connections. More importantly for our students, it's an opportunity for them to translate our school's mission into action, thinking about this as a community-facing experience, an opportunity for participatory research opportunity, and looking at this from the point of view of a student-sourced idea in which they think about ways in which they could serve and begin to grow and gain some empathy in the opportunity and to build the coalition and to mature the opportunity, resulting ultimately in poster presentations. So the recent published report from the Austin Travis County Community Health Assessment highlights some key themes to which the students can address. Importantly, social determinants of health, housing affordability, the pandemic, emergency preparedness, mental health issues, access, and it highlighted the strength of our collaboration among residents and organizations serving the community. Additionally, our students can look at ways in which they can vision health equity long-term, grow communication and collaborations, think about ways to address systemic racism, improve the food system and the food environment of our community, think about quality and access to care, and provide supporting aging in place. These are the DelMed mission to which the students will choose one and thinking about ways in which they can apply this in their third year course. And so the opportunities that are presented through this course is another opportunity to re-engage them thinking about research, thinking about introducing them to IRB, understanding basics around quality and qualitative research, having greater application of quality improvement processes and tools which were introduced in their second year. Now they can begin to apply it and grow it more explicitly. We offer intersessions in which we invite colleagues to develop and grow the content for their use. And we curate and invite faculty with diverse expertise across the campus to support our students' projects. So we have colleagues with policy backgrounds, with business marketing backgrounds, nutrition, pharmacy, et cetera, who can support our students. More importantly, growing the community stakeholder and soliciting their feedback is an important learning opportunity for our students. Here are just some sample projects that have taken place. Projects involving mental health, building health careers collaborative with our high school, evaluating nutritional education programs, partnering with local community religious leaders and delivering mental health interventions and education, helping students at a second chance high school develop mindfulness and empowerment, and thinking about relocating a student-run clinic to better meet the needs of our indigent community members. We've been very fortunate in that our community stakeholders have been very interested and involved in our students' work. And this is just a sample list of community stakeholders who have been involved in these projects. And as a result of this, we have conservatively calculated that our students have contributed over 5,000 hours of community engagement and service. There's been student scholarship locally at our annual showcase and national and regional ed conferences. We have a health equity rubric that we applied to their poster. And what we've learned is that our senior students in their residency, this is a subject of curiosity. It's oftentimes a subject of conversation in residency interviews too. So they're well prepared in thinking about this and also in thinking about how the projects support their future career development. Thanks again, and this is my contact information.
Thank you, Dr. Luke. All right, and now I'm going to turn it over to Dr. Swales.
Thank you so much for having me, everyone. I'm really honored to speak with you guys and after these two amazing talks. It's a privilege to tell you all a little bit about our eye care curriculum at UT Health. I'm here representing a very large team, and I want to start by saying that we have an advisory board, and I have an amazing co-director, Dr. Champagne Langevere, who none of this would happen without all of these wonderful people. So please be aware of that. The other thing that I want to begin this talk with is by making sure that you all are aware of what the mission of interprofessional education at UT Health is, which is really starting with compelling experiences for our students. So we want IPE to be fun and we want them to want to come back. And that is one of our very most important goals. Obviously, it is for the purpose of improving their interprofessional competency and helping them be prepared for high quality team-based care. We also want innovation and scholarship for the faculty and the students, and we want to meet accreditation requirements, of course. Don't worry, deans will take care of you. But that's what our start is. And the other thing to know is that our curriculum and our entire program started by the amazing Dean Stark, who I'm sure some of you guys know, who began with Team Steps colloquia. And that was an amazing beginning. Many of our faculty were trained because of her work and the amazing groundwork that she put down for patient safety. And then it was followed by Dr. Butler and Dr. Ownby actually on this call, who helped us begin doing these patient safety-based simulations. And they were funded by the UT system, a small grant through the UT system. And it allowed us to create these patient safety-based simulations. They're standardized patient-based also, and they've been a wonderful thing for our students. However, after doing them for several years, we realized that there were a few things that we sort of wanted to grow in. One thing is that the students might get together to do a critical care simulation where they perform a root cause analysis on a medical error and then disclose the error to the patient. They have a great experience with that, but then the team dissolves. It's not a longitudinal experience. Also, we were hoping for something that was a little more focused on the community as opposed to a standardized patient-based experience. And the other thing is that since they were so clinical, even though we did our best to loop in our colleagues from the public health school and the informatics school and our non-clinical students, it just didn't have the same amount of appeal that we were really looking for. And so that's what led us to develop the eye care curriculum, which is what I'm going to talk about today, where we wanted to develop something that would fill these gaps in our curriculum. And so it is something that is both patient-centered and community-based. And that is the first thing to know, is we're sort of thinking about, I think they call it stage 4 translational research, right? Where instead of going from the bench to the bedside, you're kind of going from the bedside to the community and back. Focused on underserved populations. The idea is that we bring teams together in a longitudinal way, and that they would be able to think creatively about a problem that came from a real community organization. So we've been fortunate to have a telemedicine practice going with several community organizations across the state. There are 2 in the RGV and 1 in Houston that we've decided to partner with. And so the idea is that we have student teams seeing clients, individual clients, and then we'd have population health teams paired with them working on population health problems from that community center, right? And so they would get to collaborate, and hopefully they would come up with great solutions for the community center, and the clients would benefit, and there would be sort of a rich interchange within those teams. The other thing is that, you know, going back to the times of Dean Stark, we had some really rich discussions about the topics that we should be integrating across all of our schools. And we wanted to really realize that. And we've been able to come closer with eye care. We also wanted to get exposure to all of our campuses across the state. So our public health school, for example, has all of these campuses. And because of COVID, really, we became much more adept at using Zoom to the highest potential. And that's what we were hoping for, is that we would be able to have our teams include people in Dallas and Austin and all of you guys' beautiful cities in the Rio Grande Valley. So the logistics of this, forgive me for this slide, but those of you who do IPE know that IPE, you know, falls and thrives based on logistics. So the eye care program is between 6 to 8 weeks, depending on the specifics of what the school wants and whether they are involved in just the client portion or just the population health portion, or both. When I talk about integrating the curricula across the school, the clinical curriculum focuses mostly on delivering content related to mental well-being, nutrition, and dental health to the client. And those modules were developed by course directors at, you know, from across all of the different schools, but they also include social determinants, systems thinking, therapeutic communication, policy, ethics, you know, all of this stuff that we've always wanted to teach as an interprofessional team, and now we're finally able to do it. It also is a combination of asynchronous and synchronous modules that we deliver through Canvas. We do have at least a few protected hours, 2 hours on a specific half day per week over 6 to 8 weeks, or 6 weeks for all of the clinical students. The medical and nursing students meet for 6 weeks in a row. The dental students, and hopefully the hygienists soon, meet for 1 week out of the entire thing only. And we do run 30 to 60 teams per trimester, guys. So it is a huge endeavor. Each team includes 5 to 7 participants in the clinical teams alone, and 5 to 7 in the population health teams. We started doing pilots last winter because we've learned to do a lot of pilots and get a lot of feedback. And then we implemented this past fall. So I've not been doing this quite as long as my colleagues, but I'll show you the data that I have. So how do we make sure? What we've learned from our pilots mostly is that students find this very scary. One of the biggest ideas was that we would create self-motivated learning. So we don't grade them based on this. We try to get them excited about doing it for its own sake. I really loved what Dr. Luke was saying about professional identity formation. As a residency program director, I really want them to do this without grades. I want them to just do it to do it. And so we have to teach them that this is going to be an uncomfortable situation, that they're not going to come into eye care and just show us what they know. They're going to come in and we're going to create a situation where they're going to be uncomfortable, and we don't know what the outcome of what's going to happen in the room with the client, that they're in control of the situation and they have to start deciding what's going to happen. We also have to teach them, though, about psychological safety and about what a severe discomfort zone is and how to call stop when they need help. And so I'm going to talk you through that a little bit. The other thing that we definitely prepare them with is team steps, because I really still do, I'm sorry this is so fuzzy, I really do believe that these 4 skills of leadership, communication, mutual support, and situation monitoring are like the step stools that we can all go around to get better. So to prepare the student teams, we do 2 simulations. One is related to telehealth and vaccine hesitancy, and the other one is related to interpreters. I'm realizing I'm running late on time, and I'm sorry, it's because I'm too excited about this. But I put here the team step skills and how we help these simulations to help them develop the skills that they need to both understand when something is hard, how to look within their team for help, and then how to look outside of their team for help. And then they start working with their clients. They do it over 4 weeks. The first week, they just get to know their client, and then they work through the 4 modules. We do have a pretty detailed structure for when they're with their clients. We put them into their breakout rooms. We then have to bring in interpreters for usually about 75% of the clients. We send the interpreters to all of the different breakout rooms. Then we bring in all the clients. Then they get about 45 minutes with the clients. They do a worksheet by themselves to decide how they think it went and plan for the next visit before we do a debrief with the faculty. So it's pretty complicated. And we do give them quite a bit of structure with the clients, like what to say to open, what to say to close. We give them some basic structures for how they could talk to the clients, because they can be quite nervous. And we also give them slides like this so that if the interpreter drops, they don't like freeze and look strange in front of these community members, because we want to be very careful. Just for some outcomes, last semester, we did our first session and we served 40 clients for 4 weeks. We got 231 students through the session, that's the clinical students through. And about 80% of the students said that they learned something or learned how to collaborate better, which was nice to see. And they wrote some nice comments that they learned communication and community engagement in public health is key to improving community health outcome and quality of life. And they learned other things like how powerful conversation is. I think a lot of them felt like they wouldn't have anything to offer their clients. And they were really happy with the fact that a lot of community members were so grateful to just have authority figures, which is how they see our students, sit and listen to them. So we found the whole thing to be very impactful. The project wrap-up happens after the 4 client meetings. This is when the students who are doing the projects have some time to meet and develop their project presentations. Then there's sort of a competition to decide who gets to present to the CEOs of our community partners. And these were the projects that we got back. This is just some of them. But some of the community partners need help with safe places to exercise. Some need help with access to health services. Some people want handouts for their clients on options for healthy, low-cost meals. And so the students pitch this back to the CEOs, and the CEOs give them feedback. And some of the CEOs have asked us to give these materials to them. So in summary, our program started with SPs and team steps and was great, but we're really excited that now we have iCare that's more longitudinal, community-based, and lets students apply their knowledge to real clients and communities. I would say that the biggest thing we've learned is that students require a lot of structure and support to require such a transitional learning environment, but we still have encouraging outcomes, and I'm looking forward to seeing what we learn. Hopefully, the online flexibility and creative solutions that we're working through will make it applicable to other programs over time. Thanks for listening, everyone.
Thank you. That was excellent. Okay, so now I want to open it up for Q&A for about 10 minutes. So feel free to unmute and just jump in.
This is Herbert DuPont calling, speaking. I want to deal with the first talk on diet. I didn't hear the word microbiome spoken, and the power of diet in modifying the microbiome is amazing. And I think diseases can be reversed or controlled by attention to the microbiome. We're involved with fecal transplant and just finished a study in Parkinson's disease showing we can improve that disease. And we've done it with many other things, but I believe diet could do the same thing. with prebiotic food, particularly fiber, particularly soluble fiber, we could alter the microbiome in very important ways that would be health beneficial. And particularly in the hospital setting, where patients are receiving antibiotics and their microbiomes are totally disarrayed, and the coliforms, the Enterobacteriaceae, overgrow and produce superinfections. If we paid attention to their diet and their microbiomes, I think we could prevent a lot of that. And so I'm really a big, strong proponent of diet, and diet as a medicine, not just to treat protein caloric malnutrition, but to treat diseases and prevent diseases.
Absolutely agree. And I would say that's a perfect example of the kinds of things that are increasingly research priorities that students want to talk about and ask about. And so we're able to tailor what we teach to their interests in that way. And one of the things that my dietitian always comes back to when she's teaching them about microbiome and food is that it's really about variety of diet, that the data is pretty clear that you have a more diverse microbiota, the more diverse your dietary pattern, and eating the foods that are high in fiber. And a lot of what we do is the practical stuff, such as, okay, I eat a low fiber diet as a typical American does. You don't go from 0 to 60 in working with a patient to get more fiber in their diet. How do you really practically help someone work through specific food-based changes that get to closer to dietary health in fiber requirements? And so I think people need a lot of hand-holding in dietary change, and we are not equipping health professionals to do it until recently, when attention has been increased to this. But I absolutely agree with you. It is a treatment, it is a prevention, it is an intervention for almost every health condition that we study. And we have a very interesting dermatologist doing research here on how microbiota of the skin is linked to diet and is linked to eczema, psoriasis, and other conditions. And so I think we will continue to see dietary linked to almost every major health condition. And we've been neglecting a very affordable treatment approach for a long time, but hopefully that's going to change.
Right.
Dr. Alvin, this is Harold Henson from UT Houston School of Dentistry. I was thinking you need an oral health component also to your IPE, because there are a lot of oral diseases that's very directly affected with culinary medicine. So I'm just FYI.
Sure. And I know dental students take culinary medicine in Houston, or at least they have in the past with one of my colleagues. That's unfortunately not there anymore, but I hope they still take it. We don't really have a dental school representative on our campus, but that would be an amazing way to bring them in as a guest lecturer to expand students' thoughts about that. But you're right, it turns out that when people follow a healthy dietary pattern, many of their dental health problems go away.
And do you envision culinary medicine becoming a specialty in the future?
Well, so it kind of already is.
It is, okay.
I'm certified as a culinary medicine specialist, which is about 60 hours of CME that's done independently, and then a lot of hands-on training that I originally did with Tulane's Goldring Center for Culinary Medicine. And we now have a national culinary medicine specialist board that trains physicians, nurses, APPs, dietitians, clinical pharmacists. I may be missing a category. Clinical diabetes educators can also get certified. And there's just over 400 now in the US. And I would also add, I did get board certified in lifestyle medicine as well, which includes a lot of nutrition education, but really applying the interprofessional approach in a teaching kitchen, I think benefits from formal culinary medicine education. And last thing I'll say to that is we actually started a clinical consult service that's a physician dietitian partnership, and also brings in our social work team and community health workers. So we're exploring a combination of consults that are individual as well as group shared medical appointments in a teaching kitchen as a clinical model.
Thank you. Wonderful.
Dr. Alvin, this is Gabe Eisenberg from UT Houston. I fully agree with the concept that we really have a poor training both before graduation and after graduation in anything that has to do with nutritional medicine. But I also have to bring to the attention that the population doesn't have much knowledge of that. Of course, they don't have formal training, but there is a lot of subliminal or not so subtle campaign about, let's say, the Ozempic effect or something like that. I mean, how do you deal with the reductionist approach that the community carries with them, and do you have a strategy to refocus on the value of nutritional medicine over the simple way out or easy way out of using medicines to deal with dietary problems?
You know, that we could spend an hour probably addressing that question. So just in brevity, I will say that we ultimately function as coaches. That's how I like to think of my role as a physician. I am a coach for my patient. And my job is to be able to connect, or to first define what their health goals are, what health means to them, and what their why is for that. And then to connect them to the lifestyle strategies that will help them to best achieve their goals. And that being said, the limitations that different patients have, the preferences, the cultural drivers, all of the different factors, we have to figure that out as a healthcare team and then create the best approach that will help them achieve their goals. And I'm a big fan of not allowing some ideal of perfection to be the enemy of better. And if a patient is utilizing a lot of medical therapy to try to hasten results, then I'm not going to throw out my efforts to continue to help them to transform their dietary quality. But I do think that it is really difficult for people. We have a lot of policy change necessary in our food culture to make it accessible for someone to eat an ideal dietary pattern. Because as somebody who has the knowledge, the education, the finances, the skills, and a partner who cooks as much as I do, it's really difficult in a two-parent working household to do it right all the time. And so how do we make it the easy choice? We need the whole community involved in that. We need policy change. We need health economists to help us support nudge architecture. We need school changes. And I see Dr. Maloney's mentioning Wes McWhorter, who's a good friend of mine, that's a PhD in dietitian that really launched this at UT. And I think that there's so many people all over the country passionate about engaging this, but the most important thing is that we meet people where they're at, they don't feel judged. And we also promote food as medicine, not as instead of medicine, but with medicine. And the good news is that if you adhere to a nourishing lifestyle in diet and activity and sleep and stress management, you're likely to need fewer meds. That's the long-term goal. Some people will achieve that. Others will end up needing both. And I think we can find lots of answers that include better dietary pattern for everyone, and particularly for children, so that we can prevent a lot of these things.